intro. So welcome to the ANPA series webinars. On today's webinar, we're going to be talking about telehealth. We'll talk about the technology, coding, and reimbursement. I'm going to mute everyone right now. So we're going to mute everyone. If you want to talk, just unmute yourself. This will help us minimize background noise. Okay, all right. At this point, I would like to introduce our national president, Dr. Charmaine Emelife, if she's online. She can talk about ANPA. Charmaine, are you online?
What did you want? Oh, let me see. But right
now, if Charmaine is not online, is our president-elect Chris Okunsori online yet? He just called. He just texted me. He's having some connectivity issues. But ANPA is a 501c corporation incorporated in 1995. We're about 26 years old. We represent over 4,000 physicians and dentists and allied health professionals of Nigerian birth and ethnicity and friends. The reason why we're talking about telehealth is during COVID-19 pandemic, all of our life has been changed. In order to minimize transmission, telemedicine has become very, very popular. And today we're inviting people that have expertise in this area to kind of teach us how to use telehealth and how to code from it for reimbursement, and so some of the mistakes that we can avoid with telehealth. Some of the ANPA's benefits: we do a lot of professional development, leadership opportunities in ANPA, practice referrals, networking. We support ourselves in times of need and times of joy. Of course, one of our biggest
Chris is here, Stanley.
Oh, Chris, are you here?
Yes, I'm here. Yes, I'm here.
Okay. Can you? I just briefly talked about ANPA because I know you were having some connectivity issue. Can you maybe talk about some of the ANPA's benefits? Why should somebody join ANPA?
Yeah. So thanks, Stanley. I'm on the phone. I sort of had some technical difficulty joining you online, but I think we can go through this motion. First and foremost, I want to say a big thank you to everybody who has taken time out of their schedule to join this webinar. I think, again, incidentally, we have 2 ANPA members who are, going to be talking to us today as we work on trying to, go through this crisis that we have found ourselves. So, like Dr. Okoro was saying, why would you join ANPA? And I think we're all very much in tune with a couple of things he just said. One is the leadership development opportunity that we all get to receive as members of ANPA. We're going to now hear different people speak about leadership, and hopefully we have a couple of take-home messages to help us develop ourselves. There's also the opportunity for professional development. So we actually provide CEs at our meetings, and this professional development, brings to bear, some cutting-edge things that are happening at this point. And we are able to quickly key into things like that. There's also opportunity for practice referral. So I think it's also a good idea to continue to participate in ANPA. And there's also the really key part is the networking. We're able to, amongst ourselves, engage in some kind of networking, assist ourselves. And there's also time for, support. If anybody is excited about something, we're all excited with the person. If anybody is not happy about something, we're all in the same boat and trying to help them. So I think at the same time, we're also engaged in medical mission and volunteerism. The different chapters do different things. As a national organization, we are very much engaged in medical mission, and it's also a flagship project or a flagship program for us. So for those of us who are already members and for those who are not members of ANPA, I'm hoping that all of these opportunities will help us have a rethink and think about joining ANPA and become active members of this great organization of ours. So at this point, I would say thank you, Stanley, for this opportunity, and to the speakers who are taking time to share their knowledge and expertise with us.
Okay, thank you very much. So today we have Kingsley Abaiwe. He's a clinical informatic and hospital medicine here in Atlanta, Georgia. I've known Kingsley for a long, long time. Shegun Daudu, I can't even pronounce all of his degrees. It's so long, but he's a doctor and a lawyer as well, an MBA. He's a board certified clinical informatician. They're both gonna share their perspective on telemedicine. So today I'm learning as you're learning how to use telemedicine and all of the things that you can, because you can also get yourself in trouble using telemedicine. So let's learn from the experts and then make our practices better. So some of the topics that they're going to be talking about is how to implement HIPAA compliant telehealth platform for your practice and how to pick the best ones to use, avoiding mistakes and doing all that stuff. You gotta get paid somehow, right? What you need to know, what are the latest code, what you should or should not code. So with that, further, I'm going to be introducing them very soon, but remember they are giving ideas, not advice. So the opinions given are for educational purposes only and provides general information and basic understanding of the applicable laws. Okay, and since we have an attorney, this does not constitute an attorney-client relationship. All right, without further ado, I'm going to, Kingsley, you're going to go next, okay? Are you there, Kingsley? Dr. Abaiwe?
Yes, can everyone hear me?
Yes.
Great, okay, thanks. Thanks, Stanley.
Can you see your slides?
Yes, I can see my first slide, great,
Okay.
and I'll have you advance it when I'm ready. So Stanley, thanks for the introduction, thanks for all you do, and thanks for putting this together and also inviting me to talk on this very interesting topic, because these are not normal times. But I also thank you for the disclaimer, and also Stanley, you're not going to learn much from this because you're not new to this. Telemedicine is certainly not something you're unfamiliar with. But without further ado, next slide, please. So I'm going to be talking about telemedicine in today's environment, and just a brief understanding of what telemedicine is. It's really defined as the remote diagnosis and treatment of patients by means of telecommunications technology. And there are a myriad of ways that we can communicate remotely, audio, visual combinations, we can use biometrics, etc. Some of you may remember, if you're at the ANPA conference a couple of years ago, I spoke briefly on one of the hot topics on telemedicine in a developing nation. So there may be some commonalities, but obviously with the COVID-19, this has come to a new level in terms of the industry of telemedicine. So next slide, please. So I'll be talking about the how to set up a HIPAA compliant telemedicine practice, in addition to a few other sections. But just an overview of telemedicine. It's really a real-time communication tool that I'll be talking about. And then another part of that would be a store and forward type technology, which is collection of data that you can use at a later date. And then I mentioned the remote patient monitoring tools like biometrics that we can use from afar in real time. And then verbal audio, some of you may be familiar with these from your check-ins or portals in your practices. And even sending text to patients can be used as a way of communicating with patients remotely. So when you're setting up these things, just bear in mind that you have to define the medium of communication and make it easier for your patients to find you. So next slide, please. So I'll be talking about how to implement a HIPAA compliant telehealth platform first of all, and then I'll talk about picking the best telehealth platform for the practice, in addition to common mistakes that you can find with telemedicine. So next slide, please. Next slide is this. Okay. All right. So looking at the COVID-19, I mentioned that these were not normal times. If you look at the Johns Hopkins website that Shegun had actually shared with us as a link earlier, yesterday when I put my slides together, we had about 330,000 cases of coronavirus. Today, we've got about 360,000 and we've got more than 10,000 deaths. So this is really a big deal. And I urge you all to stay safe. Really, this is a good opportunity for us to come together and see what we can do in terms of flattening this curve. Going back to the telemedicine industry, it wasn't really used a lot, even though it was really supposed to have gained ground about 5, 6, 7 years ago. But up to 1%, only about 1% of US claims were really used up to 2018. And this was mainly due because there were not really good regulatory ways of enhancing adoption, and patients preferred the face-to-face, and then older physicians also were not really familiar with it. But with this COVID-19, we found that there's really a tipping point has been reached. It's almost as if telemedicine was built to help deal with this pandemic. So the Trump administration just passed the CARES Act, which was for $2 trillion. And part of this is the FCC component, which is the $200 million part that is really helpful in terms of using the money to be able to enhance the adoption of telemedicine services to all providers. So you'll find that in the way things are going now with the COVID-19, we have to prevent emergency rooms from being overcrowded. Telemedicine is a good advantage. We can also limit exposure amongst healthcare workers to people that are infected, and we can decrease the use of personal protective equipment as well by keeping patients at home. So this is really like a boon to telemedicine, and you find that shares have increased in a lot of telemedicine companies. One company I work with, I don't own shares unfortunately, but their shares have gone up by more than 50% when other shares are going down. So you find that in this pandemic, this is really a paradigm shift, if you will, for telemedicine. So next slide, please. The picture you see there, it looks kind of, it's a kind of a connectivity picture, but I put it there just to underscore an example of what's happening in South Korea, where they've done a much better job, unfortunately, than we have in terms of battling the coronavirus pandemic. You see, to the left, you see a screen, you see a sensor, which looks like a pulse oximeter, and then you have a watch like a smartwatch, then you have a handheld device, and you have a monitor. And this really underscores the connectivity in telemedicine. For instance, when they're tested, and testing was done very broadly, they would actually have people download an app on their phones, and the phones, they would take them home. They would be able to use the GPS to know exactly where they were. So if they were not socially isolating, the authorities could tell. They would check in with their vitals about twice a day, including their pulse oximeter, their respiratory rate. And these things were taken real time to a repository. And there were healthcare workers at the other end that were constantly monitoring these for complications. And they were able to monitor and really flatten their curve pretty early on. So this is an example of how telemedicine can be used under the right circumstances. But next slide, Stanley. Let me go back to the implementation of a HIPAA compliant platform so I kind of don't digress too much. Like I mentioned earlier, the HIPAA laws really have been relaxed during this pandemic. And part of what was done was that the laws for these, the HIPAA laws for the pandemic have been relaxed due to the need to get patients seen as quickly as possible. It's really important to understand that when you're implementing from your practice or in the hospital, you have a long-term strategy in mind, because this will pass, this pandemic will pass, but telemedicine is here to stay. So it's important to set your team up for a rapid launch with the right set of people, and also make sure that your that your malpractice insurance carrier is on board, because your policy has to be able to cover the care from a malpractice standpoint involving telemedicine. It's also important to familiarize yourself with payments and policy guidelines that the different telemedicine practices will require. So that's also an important section of implementing the telemedicine practice. Next slide, Stanley. Another thing you need to do is to check with your existing EHR vendor to see if there's any functionality that already exists in your EHR. For instance, I know that Epic, they have this MyStar, which is a good portal that you can use as a third party. It integrates with different third parties, and there are components that really have to be used properly. So a lot of other health systems are increasing their health visits weekly in record numbers. I know that in my organization, they were going from struggling with implementation or adoption to, scaling up like almost by 500-600 visits per week in terms of the telemedicine facility that they have. Some out-of-the-box packages can be deployed rather easily, but you have to be careful because now there are a lot of telemedicine vendors that are just kind of jostling for the market. So some may not really integrate well, and that may lead to you maintaining different platforms. Sometimes you may have more than one platform, like 2 platforms running side by side, or not good integration. So it's really important to make sure that you choose the right platform when you're implementing your telemedicine. It's also important to reach out to your state medical association. Sometimes that can help with vendor selection, contracting, things like that. So, but it's important to bear in mind that your HIPAA is compliant. There are different rules in terms of remote communication products. Some of you may be familiar with Google Hangouts or Apple FaceTime, Facebook Messenger, WhatsApp video chat, Zoom, Skype. These are called non-public facing remote communication tools. Now they're actually acceptable in terms of today's HIPAA, but some other ones that are not acceptable, like Facebook Messenger, Google Hangouts, WhatsApp, they are not really used as much, but they're also good. Things like TikTok, Facebook Live, Twitch are more socially oriented, and they are considered public facing, so they're not really recommended, and they're certainly not HIPAA compliant. So it's important to understand that who has access to the data, all your patient information, and who owns any of the information that's launched during those visits. So I wanted to mention that. And finally, you need to really get clear on the pricing structure, because some have monthly flat rates, and then some other ones might be per call or per visit. I know that doxy.me has a free version, but they also have one that's upgradable to I think it's per provider or even per group. So just be aware of the options that exist out there when you're setting up your HIPAA. Next slide, please. So the next slide is, let's go on the next slide. So in terms of the questions to ask, and I put together some questions that are really important for you to ask. One is if it's supportable across all the devices. For instance, you have to know your patients. Do they have handheld smartphones, or are they, do they have laptops? Are they savvy enough on the computer to be able to use? That's really important. So you have to know that the platform you're using, is it supportable across all devices, or is it just particular ones? Is it equal or better quality? The care that you're going to provide, is it equal or better quality than the inpatient care? A lot of our patients just want to see their doctors. You know how we are. They want to see their doctors. So you don't want to, kind of reinforce the fears that they already have in terms of not having the same or even better quality. Accessibility is one thing, but if it's a visit that they feel they are rushed, or they feel that you're not really addressing certain issues, then patient satisfaction scores will not be the same. And the remote patient monitoring, if you want to do that, it's possible to do things like audio. Sometimes you can have them weigh themselves, or blood pressure things, or there are some platforms that can actually do more than that now, but they tend to be more expensive. So I think that's probably not something that most practices will be doing right now, but that's more of stuff to come in the future. So I think it's important to ask about your website manner. You don't want to be kind of like wearing your pajamas and seeing patients, or waking up first thing in the morning, you haven't showered. Make sure that you address things, and it's also on both sides as well. Make sure you know that the environment is quiet, and that goes for the patient as well. You have to educate them, make sure that they're in a quiet room, that kids are not running around, or they're not driving when they're doing their visits. So things like that. But overall, I think it's most important for the patients to be able to use it. So ease of use is also a question that you have to ask in terms of when you are implementing your device. So next slide, please.
I'm trying to get it start to run by itself. Okay, right there.
Okay, so what I think I see is the slide for determining the patient protocols, right? I'm front-train the providers, yeah. So it's really important to train your team, but you have to understand your workflow protocols before you do that. It might be important to consider either a short survey of questions that patients can answer either face-to-face, but in these times, maybe electronically, or when you're scheduling them to triage them, you can actually ask them, what their preferences are, and you can kind of gauge their compliance or potential compliance. If you know your payer mix, which most of us do, you might want to reach out to your payer. Sometimes it's important to know if your insurance is going to be behind it, not just for the COVID-19 period, but even beyond. Like, say, some payers might pay temporarily, but then when all this is over, they'll stop paying. You want to make sure that, like I said, telemedicine is here to stay. So you want to make sure that they're in it as well for the long haul. Another thing is you kind of want to make sure that you can determine what part of telemedicine is going to be part of your daily schedule. For instance, are you going to make out just one section of your day, for instance, maybe morning or afternoon, or maybe 2 hours, or is it going to be random? Because it might not be practical in terms of your workflow if you're going back and forth between patients in the office, and then you're going to a room to go take a teleconsult, and then you're going back and forth. So it might be a good idea to determine maybe if there's a set block of time specifically devoted to virtual visits in your office. And I think I mentioned this earlier before in terms of the website manner. You need to really set up practice space in your office to be able to accommodate these telemedicine visits. It could be like maybe an exam room or some quiet place where you can have clear and complete communication with the patients. And if other members in the team, like maybe medical assistants or nurse, are going to be helping, make sure they also understand the setup of the technology so they also can communicate virtually with your patients. And then very important is your bandwidth and connectivity. It's one of the worst things that you can be set up and you have a nice fancy system and you're ready to go, and then all of a sudden, there's bad connection and you're dropping calls, or patients can't get through, or, one of the platforms I work with had that happen not too long ago. They had so many patients waiting, and it basically crashed the system, and patients were waiting for hours on end because a lot of organizations can't really deal with this. So the volume is not really the problem these days. It's really the bandwidth and connectivity. So you really have to invest in this. So next slide, please. It's very important to document the visits. It's not the same thing documenting a teleconsult. So if your platform is not a seamlessly integrated one, then you may have problems in terms of quality metrics. For instance, if you are using, like, say, your BMI as part of your quality reporting, and you're not getting that from your telemedicine visits, you'd probably be better off removing those telemedicine visits so that you're not dinged for not meeting your metrics in terms of, say, weight or blood pressure, things like that. It's very important to, and this also will support the billing for your telehealth visits as well in terms of your documentation. So bear that in mind. It's really important to obtain advanced consent from patients when you're doing telemedicine. There's something called a BAA, which I believe stands for Business Associate Agreement. That is a document that is signed on both sides, and sometimes technology vendors might be able to help with this. support, and most good systems have it incorporated with even the verbiage already. But if not, you can download it from the internet and just scan it and put in your system. You should always let the patients know that your practice is always, is offering telehealth services anytime they call. I think I mentioned this briefly before. So communicate clearly is really important. Sometimes just send out a nice letter, or you could post announcements on your website or patient portal, or any kind of patient-facing communication that you have in your office is a good way. But generally, you want to have a plan for supporting the patients in terms of how televisits are based on your own practices, technology, and your patient character and the workflow, of course, so that you avoid disruptions in care. Next slide, please. Next slide. Yeah, so let me go on to the next section. And again, I'm not really endorsing the promotions of products or services of any vendors. So just thanks again, Stanley, for the disclaimer. But these are based on my own experience with some products in the industry that I have recently, or maybe not so recently, become familiar with. Next slide. So we, slide do I see? Is that?
Doxy.
Doxy. Okay, so yeah, so Doxy is something I just became aware of. It is HIPAA compliant. It generates the business associate agreement. It's there's a waiting room with a queue. There is it doesn't require any special application or special software. It's out of the box, ready to go type thing. I had it on my phone and I used it, and the patient gets a link, and again, it's free, which is really, really good for a lot of small practices, but you can upgrade. The upgrade has better resolution and better video quality. And if you see the next slide, you see a little picture of my screen shot that I did on I have a smartphone and I used that. And I think you can see, that's me there. And Kwavi was my test patient, and she kept me waiting I kept her waiting for about 7 minutes, which is not a good thing, but in these times, I'm sure we'll do worse. But that's kind of what it looks like. I did a little screenshot. Another screenshot I have is from Teledoc, which I've been using for about 2 years now. I sold my practice. I just do hospital medicine and medical informatics now, but I do Teledoc, so I still have patient care remote, and I tend to prefer the audio, although I do videos. There's a little bit of difference in terms of reimbursement between audio and video. But if you hover over the phone-looking piece on the left, and then the other one is video on the right, the screenshot on the left shows average. This was actually relatively busy before the coronavirus hit. And if you see the screenshot on the right, you see the number. They actually stopped counting at 200 plus, at 200 patients. So that's the number of patients on the queue waiting to be consulted upon by a physician, and almost as many by video. So this could be anywhere from 201 to maybe 400 or 500 patients waiting to be seen. So again, the industry has really been bowing under the weight of the demand for telemedicine. So anyone that, even if you don't have a practice and you just want to do like locum and just sign up for one of these telemedicine companies, and there are many, you can make extra income, tens of thousands monthly really, by doing telemedicine from the comfort of your home or anywhere. So anyway, so next slide. So the final piece of what I'm going to discuss is really, it really speaks for itself. And I think I've kind of covered these before, avoiding telehealth mistakes. In the past, lack of awareness was somewhat of an issue, and that's not really the case anymore because everyone's aware of telemedicine. It's really just everybody wants to get on board now. So it's not really an area of concern. The expense is not really a big deal these days because there's so many incentives for telemedicine now. This is a good time to really jump on board. The inexperienced, unwilling provider issue also is not as big a factor as it used to be. A lot of physicians are much more savvy with EHR implementation. I kind of compare the the uh, the Act, the CARES Act, and the FCC part, which is for telemedicine, to the HITECH Act of 2009, which was part of the Economic Recovery Act. What the Economic Recovery Act and the HITECH Act did for EHR implementation in terms of taking practices from, say, 15% adoption to about 70, 85% adoption over the subsequent 5 to 7, maybe 10 years, is similar to what this act is going to do for telemedicine, in my opinion. So you find that there won't be a lot of, if you're not really on board with telemedicine now, you'll pretty much be left behind, because everything is moving forward. And a lot of companies, Google, the big players they've been involved for a while. But now with the volume that is out there, it's really a question of, like, every provider wants telehealth now, and practically overnight, the demand is for as many, even ambulatory visits as possible, to be converted to tele video demand, just to prevent patients from not just infecting each other in waiting rooms or exposing healthcare workers to the coronavirus, but long term, I think this is just going to be the way things are going. So those are, I think, next slide. So those are, I hope I, wasn't too unfocused in my approach, but that's pretty much all I have for telemedicine. And I can take questions now, or maybe at the end, Stanley, based on time.
Yes.
I'm not sure if that's the format that you have set up. But even afterwards, please feel free to email me or call me. Those that don't have my phone number, I can provide it. But I'm always willing to talk about telemedicine. And I know these, again, are difficult times, but this is as good a time as any to really adopt, implement, and really use telemedicine to the best of your ability and make use of all the help that's out there. So thanks so much for the time, and I'll yield the rest to Stanley and Shegun.
All right. Shegu, are you unmuted?
Yeah, I'm here, yeah.
Okay.
Well, I want to thank ANPA leadership and also Stanley for putting this together. And also thank Kingsley for starting this off. I'm going to be talking more about reimbursement, and I will come on later to also talk about some limitations and the mistake. It's important to note that I'll be, putting up a lot of CPT codes. This talk is not exhaustive on all the codes, but more to point out to what are the basic components of the codes. As against complexity, in some instances, it might come down to the exact time you're spending doing the telephone or the audio visual. Next slide. So there's no financial issues with what I'll be talking about. Any company that I mentioned, I have nothing to gain financially from such a thing. Next slide. So today we'll be talking about, reimbursement, then the coding, telehealth limitation, the avoid. Kingsley already mentioned some of those mistakes, but I also bring some up just for the benefit of everyone. I will be talking more in view of what is going on at the moment, which is in terms of COVID, the current increase in the adoption and implementation of telehealth. But like Kingsley said, this is going to be mainstream as time goes. So whatever I'm advising you to do now will be initially to help you get over the current issues, but you also need to plan long term because they become very relevant. Next one. So the CMS, that's Medicare and other groups, decided to lift the restrictions on telemedicine on March 7th. Before then, rural areas allowed access in terms of reimbursement for telehealth, but since March 17, the limitation was removed, which means all of us can technically bill for telehealth. Now, most of the reimbursement, especially for something similar to office visits, they use almost similar codes, especially for the audio video portion of it, to similar to office visits. The telephone visit, the codes are a little bit different. That's just one of the areas where there might be, differences. You also see later on that there are some new codes peculiar to telemedicine. So this, again, I'm going to talk more about. Now, this benefit through the CMC, of course, is temporary, because remember what I said, that this initially medicine telehealth was limited to rural areas, and now they've expanded to everybody. But they're saying that this week, hold on until the COVID issue expires. But hopefully there will be so much gain that it might continue forever. In terms of reimbursement, this is not just for physicians alone. You also have reimbursement for nurse practitioners, physician assistants, nurse midwives, certified nurse anesthesiologists, dietitians, social workers, clinical psychologists. In some instances, your MA can also be allowed to be coded for, that's reimbursed, especially if they have to take blood or do something. There's a code for that. Next slide. So now, I'm sure you're aware of this, that for every visit, whether telemedicine or physical, there's an aspect of co-insurance and deductible, which the law says you have to collect, but that will still be applicable under telemedicine. And as against being penalized, because in the past, if you don't collect, you'll be penalized. That's kind of against the law. But now that is being waived, and therefore, if you decide not to collect the copay or your deductible, legally, you will not be penalized. But again, I need to warn that it doesn't mean Medicare or the insurance will pay you for that deductible. It's your loss. But in my own office, we don't collect copay. So that's going to be for Medicare patient, that would be 20% loss. I think it's better than nothing. So you need to be aware of that. Now, in terms of what is covered, in terms of reimbursement, normal evaluation management covered, mental health counseling covered, preventive health screening is also covered. There are a lot of other things that are also covered, which the time allotted will not allow me to go deeply into. But I have some slides that actually point to some of the codes that will point to the kind of coverage that you might expect based on those CPT codes. Now, there are three main types of virtual services that you expect through telemedicine. One's the usual telehealth visit. The second one is what they call the virtual check-ins. And then the third one is the e-visits. And I'm going to explain what they mean. Next one. So for the telehealth visit, it's the normal, patient calling, call the patient through either telephone or the audio video visit. Like I mentioned earlier on, it's similar to what you get during a physical office visit. It could be done through the telephone, and it could be done through some of the platforms that Kingsley mentioned earlier on in terms of video conferencing. The key point, though, is that it has to be synchronous. That means it has to be real time. It has to be a two-way communication. It can't just be, any other way, not real time or, at least that for the telehealth visit aspect. Now, the rule for this is that it can be for new patient. It doesn't have to be for an established patient, which means a new patient can be seen through telemedicine. Now, of HIPAA regulations, not using, not securing, not having security, confidentiality, and privacy issues as required by HIPAA. But the Human Health Services Office of Civil Rights decided that they would not enforce any penalty against a practitioner who doesn't follow the HIPAA regulations. Now, what does this mean? It means, therefore, that if temporarily you're not using a HIPAA compliant platform, you might not get penalized. But again, based on what Kingsley also said, you have to start thinking, and what I'm saying also, you have to start thinking long term. So while you might temporarily want to use might not be HIPAA compliant, you have to understand that long term, after this COVID issue is all over, you might need something that's HIPAA compliant. But again, having said that, the also caveat to this is that you have to do this in good faith. In law, the definition of good faith means you have no bad intent, no malice. You understand? You can't say, this my friend is going to take my wife. Let's go and do telemedicine in a public place so people can see what is going on. That's not being good faith. I'm just giving that as an example. So like today I saw a patient who was in the grocery store, telemedicine with me. So I had to kind of, I reminded her of the issue of privacy, and then, it was recorded. So she consented for me to continue talking to her, which I did, that I immediately had to take a consent there to be sure that I covered myself. I was doing this in good faith. So it's also a good thing, just from what I've just said, to also make the patients be aware of the privacy issue, especially when you're using a non-HIPAA compliant platform. Again, all this requires taking, from a legal perspective, taking a prior consent for you to be able to use this platform. So it might be a situation whereby you might ask the patient to sign a document and email it to you, or, that's probably the only option now, but in the future, if they're in the office, you explain this to them and they're able to sign a consent in terms of what you're going to be doing, the platform you're going to be using, the pros, cons of the platform. Next slide. Now, the telehealth visits, repeats what earlier on. So the video communications that involve using public-facing are not allowed, and these include Facebook Live, Twitch, TikTok, and so on. I didn't know much about TikTok until my young daughter told me, kind of made fun out of me. I thought I was like a nerd when it comes to IT, and I didn't know about TikTok. But it's kind of, the key point is that it broadcasts to anybody who is on that platform. So you don't want to use that because everybody on that platform sees what you're doing, as against a two-way traffic whereby only two people are seeing that. That's very critical in terms of citing libelous actions. So we need to be careful about that. As mentioned earlier on, you have to think long-term, right? So even though we something for some people, you can't just say, oh, just for now because I need to make sure there's revenue coming in. It's good to think of what you can do short term, but you also need to start thinking of something long term. And therefore, short term, there's some of the long term platforms were already mentioned by Kingsley. Some of the short term platform might include the Microsoft Teams, which used to be Skype for business. You also have Zoom for healthcare. Some of these are also incorporated into some of the existing electronic medical records. Zoom is the background platform for Epic, which is what I use. So you have GoToMeeting, you have WebEx meeting, there are tons of them out there that you can use. And, so if you Google them, they are the applications you can
Did we
connect.
Sugar? Okay.
Can you hear me?
Yeah, we can hear you. I think your connection is coming in and out, but we can hear you. Go ahead.
Okay. All right, next slide. Now, so for the telehealth, the codes, the common codes, CPT codes, for new patient is, like I mentioned, it's not really totally different from when you have a physical office visit. So 99201 to 99205, because there's no really physical examination, is the level of complexity, which means the history of presenting complaint, then review of systems. Now, depending on your specialty, you can also include physical examination, skeletal spine person. So part of my physical examination, I tell the patient, like for the neck, I tell the patient, turn all the way to the right, turn all the way to the left, look onto the ceiling, touch your arms. Do you feel any tingling, numbness? So those are all the things you can do during physical examination to document. You can ask them to come closer to the screen so that you can look into their eyes, open their mouth. So you can do some of those physical examination and document them. At least, from an MSK, that's musculoskeletal point of view, that's kind of pretty easy. Now, most of the codings, you don't have modifiers, and they're not required. Modifier 50 for, some bilateral things you might do. But there are some specific modifiers, like the GO for diagnosis and treatment of acute stroke, in case you are involved in as a neurologist. The GQ, that's used in Alaska and Hawaii, because those are rural areas sometimes. And then the GT, which is a code that's used in critical access hospital. These are rural areas where, they want them to survive because they don't have that many patients. So they kind of use a different code for higher pay. Now, for those who bill, I'm sure you understand that for every billing, you have to state the place of service. Most of it is 11, is 11, for office visit. But for telehealth, the place of service code is 02. So you need to remember that, because if you code in telehealth and you put the place of service as 11, that's 11, which is your office, that's not true. But there are instances where you might want to do that, and that would not be under telehealth, that would be under the virtual check-ins, and also because office, and also with the e-visits. Next slide. Next slide. Now, so, all right. For subsequent visits, for the audio video, you have the 99212 to the 99215 codes. And this is very time specific. The 212 is up to 10 minutes. The 213 is 11-15 minutes, and then so on and so forth. So the way I've explained this to people is that if you schedule someone to, probably your schedule is 30 minutes, for, follow-up visits, or 20 minutes, you can just know that, if they check in 5 minutes before, your MA or nurse is able to take few information, you might be able to therefore build the code 99213 or something like that. If you think you will spend more time on the phone, I want to go to 994. But it basically comes to that. Now for telephone, that is kind of different. Remember, the audio video is really video conferencing. But if it's just telephone calls alone, then it's a different code, and that's the 99441 to 99443. It's very critical, because now the scenario would be that a patient might not have access to video conferencing. So you schedule the patient for telephone visit. Then the code should be telephone visit. Now, in a situation where you actually schedule the patient for audio video conferencing, but something happened, the patient could not connect, you could not connect, and you change it to telephone, we still bill for video conferencing, because that was what you planned to do, even though that's not exactly what you did. But it's been said that you can actually bill for the video conferencing, because that's what was, efforts were made. Slide. So this is just summary of what I've said so far. The top area of 99201 for new patient. The next, column you see on the left side, the 99212, for evaluation management through the telehealth. On the right side, the 99441 to 443 being the telephone evaluation. Next one. These are more codes, but again, like I said, I'm not teaching about codes and billing, but just to make people aware that whatever you're doing, a lot of these codes are there. And therefore, if you go to, people can email me and I'll send them tons of documents from AMA and from CMS about these codes. Some of these codes, could be related to emergency department visits. Now, people might say, oh, is that possible? But like emergency department visit, for example, I'm at home, somebody calls me for a consult, somebody is in the hospital with back pain, and, what should they do? I can connect to the emergency room through the telemedicine and do the consult. I can bill for that, so it doesn't mean I have to be directly in the emergency room. That's one instance where telehealth might be, relevant in terms of reimbursement. Next one. So same thing. A lot of number of codes. A lot of these, obviously, they relate to the doctor through telemedicine or audio, connecting to a specific areas. It could also be your office. Those of us who do MSK, musculoskeletal medicine, we do have therapists who work with us. They might call the patient, put them through some physical therapy sessions. They can also bill for that. So you shouldn't fire a physical therapist because you say, well, they're not going to be around to show people how to do therapy, but they can through telehealth. Next one. Next one, yeah. So we've spoken about telehealth. The next one is the virtual check-in. Now, the virtual check-in is basically, we're already doing this without getting paid for it, So patients will call in and say, oh, I need to talk to Dr. Daudu, blah, blah, blah. This thing is needed. Now, this, so there's a bit of a confusion here, even for me, because the ruling said it has to be for established patients with existing relationship. But there are some aspects that are saying, you know what, they will take it from patients.
Are you there?
Available, that they'll be ready to pay for this.
Shegu, we lost you for a few seconds. Can you repeat what you said?
Right. Okay, can you hear me again?
Yeah, we can hear you. Just repeat whatever you said in the last 30 seconds. All
right, so what I said was that, the first bullet point, that the virtual check-in has to be with previously established patients. I mean, that's one thing, but they're changing the rules to say new patients can also virtually check in because of the difficulty in some patients getting to get an appointment with their own pre-existing physicians or practitioners, okay? And this, for the virtual check-in, it has to be initiated by the patient. Which means the patient is the one calling in and say, I need to talk to my doctor. And, and this should, not have anything to do with any previous medical office visit in the last 7 days or, telehealth visits in the last 7 days. So the difference between this telehealth is that the patient is calling, and saying, oh, I'm running out of my medications. Should I continue with my medications? Can you renew my medications? And then this comes under virtually checking. And then you also have to make sure that it's not a situation where you'll be asking the patient to come in within the next 24 hours. So you're basically offering a kind of management that will not require the patient to show up in your office. So like everything else we've said so far, the patient has to consent, but if there's no written consent, the patient must verbally agree for this process to move forward. Again, like what we said so far, the medical co-insurance and deductible will still apply, but you can waive it, but you know it's your loss if you waive it. Next slide. Now, the codes for virtual checks in, you know, they're kind of peculiar, you know, the two major codes, you know. So the first thing about remote monitoring, part of it, again, might be, you know, a lot of it, you have gadgets, you know, you have other smart watches now through which my iWatch, for example, if my heart rate goes very high to level, I set it up for that. I've never had a problem with it. But if my heart should go into atrial fibrillation, it's set up to call my wife and then call my primary care doctor. And so that kind of situation comes in virtual checking. You know, so we're going to see this in the future, you know. So the code to use, the first code is G2010, basically involves remote evaluation of recorded video images submitted by patient. This might not be relevant in many instances, but for example, using the example of my iWatch, you know, it's going to send my EKG to my doctor. So that's, you know, a recorded image being sent. It might be a dermatologist, you might be a dermatologist and you've seen a patient and the patient is sending some of the skin pictures to you. You might be primary care, you know, somebody said, you know, have this problem, they take a picture, they send it to you. And in the same rule, you know, nothing related to the last 7 days. And, you know, the patient is not going to be seen in the next 24 hours. If the patient coming back to see you within 24 hours, then you can't use this code. Then G2012 is a situation whereby the physician actually now respond by phone, audio, text messaging, email, or even going through the patient portal, which means, you know, the patient called in something, and then you reply by calling back, or you arrange for an audio, or you send a text back to the patient, email, or you decide to go into the patient's portal and then send a reply back to the patient. That will come to that. Next one. Now, so this is the third types of telemedicine contacts with the patient, communication with the patient. So you have a non-face-to-face communication that's also initiated by patient. Look at their records. And then they can also send messages. I do get that from my patient. They will send messages and I say, oh, please, can you renew my medications? Oh, you know, my pain is not getting better. Can you hear me?
Yeah, we can hear you. Can you repeat the last 20 seconds?
Okay. So, I mean, the if visit is a non-face-to-face communication initiated by the patient. So, two elements so far. Non-face-to-face. It has to be initiated by the patient, and it has to be through the patient's portal. The patient's portal is available on most EMR, through which the patient is able to communicate with the office. They're able to look at their records. You know, so through that portal, sometimes patients don't make requests, and this is where the e-visit comes in. So the patient, again, must generate the initial inquiry and not related to something in the last 7 days. And of course, the medical co-insurance and deductible applicable. The codes, they made, you know, new codes, this CPT codes 99421, 99423. And also by non-physician, like your physical therapist, OT, the other codes 2061 to 2063. Next one. This is just basic summary of what I've said so far. Remember, I said the place of service for the telehealth is, the code is 02. But for these other ones, the place of service, you know, will be 11, you know. So what we normally use for normal office, physical office visit, 11. But for the telehealth, you use 02. For e-visit and virtual check-in, you use 11. Okay, next slide. Again, these are the definition of the codes. I don't want to go through them, but they have all few things in common. As online digital evaluation management, up to 7 days, which means even if they call you every day, it has to be, you can't bill twice in 7 days. You can only bill once in that 7 days. The time you spend over that 7 days will determine what code you get. 5 to 10 minutes will be 4 to 1, 11, 20 minutes, 4 to 2, and 4 to 3 for more than 21 minutes. But all accumulative time over 7 days. So then you basically document the encounter and you don't bill until after the 7 days. Next one. This just again to further clarify the other codes for non-physicians. Basically the same concept. It's just using a different code. Next one. This is basically a summary of what I've said so far, okay, of all different things, different codes. All right, next one. Now, in terms of limitations, I mean, Kingsley also mentioned some of them, but I'll just go through them very quickly because of time. A lot of time, these limitations are based, first of all, on the fact that these things are new to a lot of us, and therefore we rush into them. So we need to make sure we understand the entire concept, seek advice. Even from a lot of specialty organizations have, offices. I belong to that of the AAPMNR, giving advice on all these things. So, the telehealth, there's no physical examination in terms of the real thing. But like I mentioned earlier on, there are many ways of doing this. You can draw up a template in which you tell the patient, for the neck, turn left, turn right, look up, ceiling, you can tell them to count their heart rate. You can ask them to buy a fig, and measure their blood pressure and record it with, or weigh themselves before the visit. So their weight, their temperature, their heart rate, their blood pressure. All this can be recorded, if by the patient and the information given to you. You need to make sure your patient has access to audio video. And I've had a lot of problems where patients would say audio video and we go in, like I'm having too, the internet connection start getting disrupted. And, so one needs to make sure that the connection is good. And, like I mentioned, there's nothing wrong in changing to telephone if the audio video doesn't work. Again, I think Kingsley also mentioned this about the video bandwidth transmission. It's very critical that in rural areas, people have in low bandwidth, everything is slow, so you might find it difficult to do audio video. Again, the limitations also create border consult and licensing. That might not apply if you are in central Pennsylvania, where I am, but it might apply if you are at the border towns of some states, where I'm in Gettysburg, where I have some patients from the state of Maryland who come in, So the question is, when they come to see me in my office, I'm using my Pennsylvania state license. But when I'm talking to them in their home, in the state of Maryland, I'm basically practicing medicine in the state of Maryland. So for now, all these are not issues, but in future, there are major issues of, can you call a patient that is the next state from you by telemedicine, because then you're practicing medicine without license in that other state. So that could get into trouble. So even for me as a lawyer, I was supposed to be an expert witness in California, and I couldn't do it because I didn't have a license. This was medicine, but coming in as an expert witness by telling through a teleconference medium. I couldn't do it. So you need to be careful of that. Also, some state laws and federal laws about prescriptions, especially opioids, require physical presence. Those are being waived for now, but again, what I'm telling you is also for the future. You got to be careful whether the patient calls you, you need to renew my Percocet. That might not work. And then the consent, and other, documents, it's always good to make sure you have all these things done, if they're not done, then, you might be in jeopardy. And then you also need to talk to your medical liability insurance to make sure they're going to cover you. You cannot presume, you cannot just assume that you're covered, you're probably covered. They're always saying you're going to be covered during this COVID crisis, COVID crisis. We used to be covered. But again, I need to also emphasize this, because even in the coverage during the COVID, what this says that if that's, they will cover anything that's not gross negligence. I always tell people the definition of gross, it depends on who the judge is. So you've got to be careful about that, because you might say, oh, this is not gross, but you get in front of the judge and the other lawyer will tell you this is gross and define it. And for reimbursement, so you don't want to work and not get paid. So you need to make sure you use the right coding. You don't want to use the coding for audio video for your telephone visit because you won't get paid. You don't want to use the normal code and put the place of service as 11 when it should be 02. Those are all the nuances that, we make your reimbursement to either be denied or come late. Next one.
Shegun, there was a request for you to repeat the limitations real quick because of your bandwidth.
All right, thanks. I'm in the basement of my house, so sometimes things. So just what I wrote down, basically, there's limitation in terms of how much physical examination you can do, but you can drop templates of things you can ask the patient to do so that you can record that. You can tell the patient to buy his fig, take their own blood pressure, take their own pulse rate, all those things you can record, and also make sure you have the right device technology that we also be able to interoperable with other things you do in the office. There's no sense in you having any technology and then you can't you might have. And also make sure that the patient has access to good connection, and including good bandwidth. The other issue is that of cross-state border. Physically, when patient comes to office, is based on the license, the medical state license for your office. But when you're doing telemedicine and you're at the state border and the patient's in another state, calling the patient might be practicing medicine across in the other state. For now, there's no problem, but in the future, there might be an issue. It's a big issue, I know that, but I've been in national meetings with the FSMB. And then we also mentioned about prescription of opioids. For now, the rules are relaxed, but for the future, you've got to be careful that you cannot write some under state law and federal law, write prescriptions, opioid prescriptions, without the patient being present. Also, you need to make sure your liability insurance provides coverage for whatever you do. And then you also make sure you code properly so that you can be reimbursed. Like I said, telephone is different from audio video. And I also said the place of service for telehealth is O2, different from office visit. The place of service for
Shegu, are you there?
Next one.
Okay.
So mistakes. So we're almost coming to an end. You know, a lot of things were mentioned by Kingsley again. Lack of planning before connection. So we need to make sure that probably a dry run with the patient sometimes, making sure they know what they're doing. I've had a patient once who had a pop blocker on, and therefore the Zoom couldn't come up. I was able to help her through quickly, and then we were able to do that. You also need to make sure that this is done within your normal workflow, otherwise you get disrupted. So for now, most patients are through telehealth. So I only do an ultrasound guided injections. So I kind of kept one day to do all that because I don't do office visits on the day I'm doing that. So telehealth might come to that where you will say, I'm going to only keep half day doing only telehealth, or a whole day or 2 half days a week doing that, so that it does not disrupt your normal workflow. Also, do not choose a non-compliant platform, non-compliant in terms of HIPAA compliant. If you want to start doing something now, you better just do the right one now, or plan to do the right one inevitably soon. And also avoid not documenting. You have to document. You have to keep record, because, if you're audited, that's only you're not going to jail for criminal, charges, so always have a backup plan. I know, like I mentioned, the video might not work and you might want to, turn to telephone. Next one. So also you want to avoid not having advanced consent, in terms with the patient, but also with the BAA, they call them the business associate agreement, which is necessary as part of HIPAA compliance. And the whole essence of BAA is that the guys providing the services are equally liable as you are for the security, privacy, confidentiality of the data coming from the electronic medical records. So it's always good to make sure you have
Shegu.
national practice guidelines, because this is what you need to be able to help yourself. And long term, you can't, I know a lot of people thinking this is just COVID issue, but, like Kingsley also said, we are in this for a long run. We'll be waiting for this for a long time. I've been involved in telemedicine for almost 20 years. I even bought a website that I thought that we were going to use, in 1999, so, but I knew it were not there. But today, we've arrived, and therefore, so we need to start incorporating that into office things. I've mentioned that of the business associate, and making sure you also. Next one. All right, thank you very much. Thanks.
Right. Thank you, Shegu. I'm going to have I'm going to unmute everyone. Let's give a round of applause for our presenters. Thank you. So we've come to the question and answer.
I had it on loud volume before I went on.
I'm going to mute everyone again. Just
they automatically mute everybody.
Mute yourself if you're asking a question. Everybody's muted right now. So everyone is muted. If you have a question, unmute yourself and ask a question. You can also use the chat function on the right in the format. Shegun and Kingsley, thank you very much for your for your detailed presentation. We're open for questions.
Hello.
Yes, go ahead. Please state your name and then the question.
Well, this is this is Buhari Osman from Maryland. This is more comment, just to comment. Thank you both for this presentation. But two comments I have. One is the consent. I think with this emergency thing, you are allowed to have a telephone consent, which the patient can sign when they come back to the office. You might not have had a pre-consent, but you're allowed to have that. They can sign that when they come to the office. The other comment is, as at last week, March 30, the interim final report from CMS states that the place of service is not O2 anymore. The place of service is more like what you will have done, seeing this patient face to face. And then you have to use a modifier 95 to show that you're doing this sort of telemedicine. So you need to look into that. So it's not O2 anymore. And that's part of the interim final report that came out March 30. So those are my two comments.
Thank you very much. Any comments, Segun?
All right. Dr. Osman, thanks for that clarification. I'm going through the update from the 30th that you mentioned, because I think I had that from the CMS and I didn't see that, but I may have to go through that. And so that might need further
I think there's a comment from Tabo. You unmuted yourself.
Yes. Again, thanks Kingsley and Segun for this presentation. I think I use UpDocs. It's through my EMR. It can also be used as a standalone telehealth option. I think my experience in the past 3 weeks or so is that the people that need telehealth the most, which are the Medicare patients who are older, less savvy, are not able to use the video part of it. I'm almost at 50% or 60% where they want to do a telehealth and then they can't connect by video because they have a flip phone and it ends up being audio, but I never get paid because Medicare doesn't pay for that.
You said Medicare or Medicaid?
Medicare.
Medicare
does not pay for telephone only. It has to be video component.
No, they do pay for telephone now, though. They do pay for telephone now. They were not paying for before. They were not paying for telephone, but under this COVID, So I need to clarify this. My lecture, I tried to emphasize what we need to do now, and also we need to think long term. For now, they're paying for both telephone and also audio video. In the past, they were not paying for telephone at all. They were not even paying for audio video if it's not rural. Then initially they said they would pay for audio video, but now they're not paying for telephone. So, like I said also, sometimes you schedule patient for audio video and the connection is bad, and then you change it to telephone.
All right. Well, I'll have to check on that. I wasn't aware that the Medicare pays. I think you had to have a video component to do the telehealth part of it.
Yeah, I do agree with Mr. Dowd. The CMS is going to pay for that now.
Okay.
They're going to pay for telephone.
Would you have a format? Just mention your name. Dr. Emero White raised his hands. Go ahead and unmute yourself.
I think Kingsley was one. Kingsley just spoke, I think.
Oh, okay. Always, just if you're going to speak, always,
sorry,
yeah.
Stanley, this is Kingsley. I just wanted to weigh in on
the
call-up before the last in terms of the 95 modifier. That indeed is correct.
Okay.
It's the same location. And also regarding the other issue, because of the pandemic, the special circumstances, the federal government did advise, they announced actually through the Office of the Civil Rights, the OCR, that they'll use their enforcement discretion, and they're not going to impose penalties on physicians that are not in compliance with the erstwhile regulatory requirements under the HIPAA because of the good faith provision. But like Dr. Daudu said, that will change in the near future. But for now, basically, they're just paying for everything. So that will be phone, audio, everything. I just wanted to clarify that piece as well.
Dr.
So, but I think what Dr. Daudu was trying to, the point he was trying to make, which I made myself, was that we should plan for long-term, not short-term, because this will pass and you don't want to be out of compliance later on when they change the rules again.
Okay, Dr. Emerwa, you are raising your hand.
Yes, please. Again, thanks, Kingsley, and thanks, Segun, for taking the time to update us and to help us in this day of COVID-19. My question is about DoxyMe, and I can take this information offline with anybody who has it, so that we don't bore people who know it and leave people who don't know what we're talking about. I do have a DoxyMe, and my challenge right now is, how do I share my waiting room with my staff? And I have a staff of about 23 people in 3 different offices. How do I do that? So if anybody has that information and can either share in the group chat or share their contact in the group chat, I can talk with them later on. Thank you very much.
Any
Kingsley, do you know that?
Does anybody have a experience with Doxy.me?
I don't have a great deal of experience, but Dr. Amaro, I could contact you later, but I have to ask, which version do you have? Because I know that the functionality is enhanced with the upgrade. So I'll ask which version you have, and then we could take it offline and see.
Yeah, I have the clinic version, because you're right, the clinic version is much more upgraded, better quality. So when I can send a text to my patient, and they would click on the link and get with me, and once they get on board, I can actually send them a text. I say, okay, I see you're here now, please hold on, I'll be with you shortly, and whatever I'm doing, I can finish it and then get to them. But where I have a problem is when I'm done with them, I put them on pause. How do I get my staff to pick up and order the labs and discharge them and give them their next appointment?
Okay. There's some question on the chat. Says, can you differentiate between the virtual check-in and the e-visit? They both sound like what we use to call telephone encounters in Epic.
Right. So the difference is, one is through direct, call in, which is the virtual check-in, and the other one is contact through the patient portal. So the keyword is patient portal. So if the patient calls into your office, for example, and say, oh, I run out of my prescriptions, can I talk to Dr. Daudu to renew? That would probably sound more like a virtual check-in. Whereas if the patient did not call, but went into our own patient portal and then sent a message, which the front staff would probably pick up and pass on to me, then that is e-visit. So it has to be through the patient portal.
Okay. Ivy, you have a question?
Yes, my question has to do with the telephone visit payments. My biller wants to know how much to charge. I hear the payments very skimpy, so I wanted to know if anybody has been paid, so that if anybody can elaborate according to the 5 levels under the phone visit coding, how much to expect to be paid, so that my biller will know how much to bill or how much to charge in that charge column?
I have no idea, since I don't do direct billing, how much actually that Medicare pays for that. It's difficult to know. But what I can, the best option, probably Kingston will know that, but I don't know. Everything is relatively new for that, so it's difficult to know how much Medicare is actually paying. But what I know is that it's not as much as the audio video visit. The audio video visit is almost like the office. The telephone is almost like the equivalent of 50-60% of that. So it's not lower, it's a lower amount.
There must be a publication somewhere where maybe if you find you can share in the e-group.
Well, can you hear me?
Yeah, who's speaking?
Gustavo Equano, yeah. So my experience is that Medicare pays 20% less for a telehealth visit. And I think most of the commercial are following that. Does that make sense?
No, it doesn't. Telehealth encompasses telephone and virtual. So you're saying that...
Well, if you do an office Medicare visit, let's say, or if you see the patient in the office regularly, you get paid $100. If you do it through telehealth, you're getting $80.
Okay, and then if you just do a phone call, how much do you get paid? If the patient is a Medicare older patient who cannot who cannot do a virtual video face-to-face, just do a phone visit, how much do you pay?
Yeah, that one I don't have any experience with. I just got the feedback for just the telehealth part of it.
All right, thank you very much.
Thanks.
No, I'm sorry. This is Dr. Kwara. No, that's incorrect. The office visit they're paying the same via parity. So whether you see them in office or via telehealth, your 99213 is going to be the same amount. And that's the same case too for Blue Cross Blue Shield and Humana, from what I understand.
Well, at this section, the last speaker said, generally is what Medicare said it will do. But I also need to warn that just because 4 months ago you've been paid $100 for 99213 does not mean that
Shego.
the paying you less does not mean that it's because of the method of not because of the method of consultation, but more because probably the rate has just changed.
So let me ask you, is it based on money that have come in already, or is that your expectation?
Both.
Okay. All right.
So yes.
Okay.
In essence, yes. Both from some that has come in and also the expectation, yes.
All right. Well, that's good news for me then.
There is a question. Can your nurse or your MA obtain the advance consent from the patient? I'm assuming advance consent for the telehealth. I think that should be fine.
Well, from a legal perspective, I would say yes, but, I think I gave a lecture at the last convention on informed consent, in which I advised, again, we're talking about long-term now, we're not talking about short-term. Short-term, you can get away with anything, but long-term, it's always good for the physician to be involved in signing the consent, That's just my own general advice. But for now, someone in your office can make the patient to sign the consent, because it has nothing to do with any specific what we call touching, because as physician we touch people,
Okay. Lawrence has a question.
Should be able to take the consent.
Okay, hold on, Lawrence. Shegu, you keep coming in and out.
Right. So, my apologies for that. I'm just going to break it down. What I said was the whole concept of consent, was to, prevent unnecessarily touching. That's the whole idea of consent from a legal perspective. But when it comes to consent for this kind of thing, it's more of an interaction between the individual and the office. So one can say that the members of staff can take the consent. But again, like I said, long term, you have to start thinking that it might be a good idea for the doctor to be involved in taking the consent. Long term. Short term, anyone can take the consent because it has nothing to do with the whole intent of consent.
Okay. Go to Lawrence. Lawrence has a question. Hey, Kanene. Question from Lawrence. Moving. Okay.
No.
Okay. You unmuted yourself. Patricia.
Can I?
Okay. Go ahead, Tabo.
No, I just want to comment before I forget about this free stuff. Free telehealth solution. We need to be very careful about it based on our experience on free EMRs. I think we need to think long term, like the speakers talked about, and buy the full, telehealth option, right? And trying to get free stuff because they rope you in, and then you get stuck with them.
Okay. Can you share a generic consent form with the group? Shegu, do you have a generic telehealth consent form that our members can modify for their own clinic?
No, I don't have one because a lot of it comes with the EMR. I don't know what I can see. A lot of them come with the platform you're using.
I do have one.
Are we getting? We're getting. Let's make sure I'm.
Yeah, I have one I can share. I will share it after the webinar on the e-group. You just have to, again, disclaimer, you have to modify it for your practice. The legal in Shegu said consult with your attorney before you use it. All right. Ivy, you unmuted?
Yes, please. I have two questions. And the first question has to do with the consent. Is it the same as a BAA, the Business Associates Agreement? Is that the same thing as the consent? And then my second question has to do with the e-check-in. Typically, when the patient calls for something, I need this, I need that, I generally just do it. But do we have to now call them back and say, I've sent a prescription, and then document it? Because there's got to be some form of communication and then documentation. So I wanted to know, what kind of documentation are we expected to do for the virtual and for the e-check-in?
Let me take this one, Stanley, if you don't mind.
Go ahead.
For the first part of the question, yes, the BAA, Business Agreement, and the consent, they're basically the same thing.
Thank you.
For the second part, in terms of documenting for your e-visits, I think it's important to clarify that they're basically what you have now, you have like 5 different types of visits. You've got at the top of the ladder, if you will, you have the telehealth visit, which is equivalent to the regular office visit with the modifier 95. Then you have the virtual check-in, which is not necessarily real time. And I think that's the G2010. And then you have there's communication to determine if an E&M visit is necessary. That's the virtual check-in as well, but it's the G2012. And then you have the just phone, which are not video, just phone visits. And you can use the e-visit codes, which are the 99421 to 23, I think. And then finally, You have the telephone E&M codes, which is like the lowest level. So, and I think each of these has to be documented clearly based on the need to justify reimbursement. Obviously, the phone calls them, just regular phones can be like a one-liner, as opposed to the E&M code, which should be as much as possible in terms of the information that you would need to justify that level of coding. So the AAFP, I think there is an algorithm, aafp.org. I think they have a little algorithm that kind of explains with like a workflow diagram that explains how to kind of stratify your coding for these virtual visits, because I know they can be a bit confusing. So I could probably send that to Stanley to share with the group as well.
Thank you.
Kingsley, there's something you mentioned. In our society, recommended that we have an electronic consent with the patient, not the BAA, to tell them the risk of telemedicine, because you're sharing, even though it's HIPAA compliant, but there could be a risk of disclosure. Just to cover yourself, we have a different electronic consent that we sign. In addition to the BAA with the provider of the telehealth platform, we have another consent form with the patient, or telling the patient that you were going to be using telehealth or electronic means of communication. Can you comment on that, either you or Shegun?
I'll let Shegun comment since he's more of the legal person here. But my understanding, and I stand to be corrected, but I thought that was all you needed.
Right. I mean, traditionally the BAA was more of an agreement in terms of the vendor being liable and agreeing to protecting the security, privacy, confidentiality of information that will be going through them, because you're talking about data. It's more of data protection. That was the whole initial essence of the BAA. But in terms of, so that is needed to protect the patient and also you as the practitioner. Now, they say that's different from the consent that you have to take from the patient so that patient can fully understand. So that consent is permission from the patient to say, this is what is going to happen, this could happen, you still agree that we should do this. So that's going to be between the practice and the patient. Again, is that clear?
We didn't hear you.
We lost you the last 20 seconds.
Okay, I'll just summarize it. So the individual consent is between the patient, who is the individual, between the patient as an individual and the practice or the physician.
Right.
The BAA is a consent because of data being transmitted between the vendor and the practice, and indirectly the patient, because the practice represents the patient in this. So the two are a little bit different in that sense, because the business associate will not be liable. With the BAA, whereas the patient agreeing you to do what you need to do is a different form of consent.
Okay, thank you. Any other questions? And anybody else want to have any questions to ask? You can unmute yourself if you have any question. If you don't want to talk, you can also type it on the chat. Okay, if there are no other questions, it is 9:40 in the East Coast. Can I have is our president online? Okay. Charmaine is not online. Chris, are you still there?
Yes, I'm here, Stanley. Yeah.
You would like to conclude?
Well, once again, a big thank you to all the participants and most especially the speakers. I think it shows that we are all very enthusiastic about this kinds of presentations, and hopefully the ANPA executive will continue to look out for how we can continue to enrich our membership with information, not only during crisis, but actually during normal times as well. So once again, thanks to everybody, and thanks to Stanley for putting this together.
All right. Thank you, guys. We will announce future. Does anybody? Okay, there's one last message. I want to also get a feedback. If you guys like this form of information sharing, we can, like Chris said, we can continue to share that. There was a message. I can't see it. Okay, so thank you. Okay. All right. The webinar is being recorded. We're going to post it everywhere. It will be on our YouTube channel. If you type in ANPA on YouTube, you see all of our videos. Tabo is going to share it on the social media. Tabo, I guess, Facebook, I guess, right?
It's on the ANPA website right now. The first two are on the website and Facebook.
Okay. So this information is readily available everywhere. So if you can get to it, it's on website, it's on ANPA YouTube page, and if all else fails, you can get. Dr. Osita Onyekure is raising his hand.
Why?
I don't know. Osita, go ahead now.
I have to unmute myself.
You're on mute. We can hear you.
Oh, okay. I was interested in, it seems like it would be useful if we know some of the platforms that people have been using and are happy with. It sounds like docsimi.com or .me is a common one. I don't have any experience with it, but if people could maybe share, not now or later, the platforms that they have used and they are happy with, that would be helpful for the rest of us. The telehealth platforms.
Well, I use UpDocs, and it's pretty good. It integrates with my EMR, and you can also buy it as a standalone telehealth option.
All right, thank you.
All right, thank you very much.
Stanley, before you close, with your permission, I just want to tell the participants here that 2 weeks ago, maybe just about that, when Stanley organized the first financial boot camp, he actually lost his mother, and he was doing that, and he was calm and controlling as he carried out this first event. So I just want us to kind of collectively, share our condolences to Henry for losing a great mom, and may her soul rest in peace.
Thank you. Amen.
Yeah, amen. Amen.
Thank you.
Amen.
Amen.
I appreciate it. I appreciate all of the love and virtue I've gotten. ANPA Georgia actually visited us on Sunday by ANPA Georgia visited us by Zoom, which was a first for me. So it was good because you're not allowed to visit. But thank you, everybody. My mom lived a wonderful life, and she had stroke about 16 years ago. Of course, complications of that kind of went downhill. But while she was here, we enjoyed her very, very much, and we're actually celebrating her life. Thank you very much for all of the love. I appreciate all of you guys. We'll be hearing from you guys soon. Thank you.
Thank you.
All right.
Thank you.
Right.
Bye-bye.
Thank you all.
All right. Good night. Stay safe. Wash your hands. Don't touch your face.
Thanks.